now I'd like to introduce our speaker for this evening. Dr. Michael Faloon is a spine surgeon with an office in Wayne and Clifton. He completed his medical degree from the University of Medicine and Dentistry of New Jersey, a residency in orthopedic surgery from St. Joseph's Hospital and Medical Center, and a fellowship in spine surgery from New York Hospital for Special Surgery. Dr. Faloon is board certified in orthopedic surgery. And now, without further delay, I'd like to pass it to Dr. Faloon. Thank you for joining us tonight.
Thank you, Parminder, and good evening, everyone. It's a pleasure to be speaking to you all about this topic. To be even more precise, I actually did a fellowship in scoliosis surgery. It was the first fellow at the Hospital for Special Surgery under these two gentlemen who, when you give talks like this, it gives you a chance to kind of look back on certain things and remember where you came from, because there's a little irony in that the majority of the work that I do now is through incisions the size of nickels or quarters. But I did get a chance to look back at some of my old talks and reminded me of who my mentors were at HSS. And this is a picture of myself back in training, where I actually had hair, with the late great Leon Root, who was the first resident in the history of the state of New Jersey, who then became the chairman of pediatric orthopedics at HSS, and my close mentor and friend there, who's kind of my Mr. Miyagi in training, of the retired chief emeritus, Dr. Bawachi. And the thing that is about scoliosis and my training between those two mentors is it's one of the few areas of medicine where my patients range from in utero to the latest of ages that we have now, and everywhere in between. So I have patients 15 years, saw them when they were children, and now they're adults, and I plan on seeing them into the future. The talk tonight, just to kind of maybe summarize quickly, what I'm going to talk about with scoliosis is, what is some of the history, the beginnings of the terms, what are some of the etiologies of it, or where do we think some of the etiologies are? What are some of the non-operative statuses and newer techniques for surgeries and treatments, and then kind of the impact that it has on adults and adult scoliosis. I'm a member of the Scoliosis Research Society, and this topic is like saying heart disease. It's not as simple as everyone thinks of the premonitions in society, or that it's teenage girls or so, and really it does have a much wider and broader affliction across the population. But I do like to point out that there's a lot of information out on the web. There's a lot of people who say things. There's a lot of disinformation, misinformation. So without any ado, I would direct you to the srs.org, Scoliosis Research Society. The website itself has links for patients who are either adolescents or adults. It has information and brochures for parents, and it has ways of contacting and asking questions on how to get accurate and scientific-based care. The other thing is with scoliosis recently, we started to look at some of the aspects that have not much to do with the spine, but more the psychology. And I do think that those websites can direct you to some societies of patients who get together and look at some of those social and psychosocial aspects of terms that sometimes they're told, and the terms are great, and sometimes the doctor is not the person you want to talk to about certain aspects of it. So these groups do provide nice outlets. So talking about the incidence and prevalence of scoliosis, there's 340 million people in the United States, and 2 to 3%. So that's basically 2 to 3 out of every 100 people has a definition of scoliosis. This chart shows, though, that scoliosis is defined by 10 degrees. And the patients who actually have curve magnitudes or curvatures larger than that are more in the 1 in 10,000 range. What is scoliosis by definition? Again, if I'm looking at someone from behind on an X-ray, the definition is 10 degrees of deviation from the horizontal. So if I draw a line down any two different vertebrae that don't necessarily match up, if that curve is greater than 10 degrees, then the term scoliosis is used. Now, you can stand different ways when an X-ray is taken, and there's a plus or minus 4 degree standard of deviation or error rate. But what's really going on with scoliosis is better defined by a three-dimensional rotational deformity of imperfect geometric torsion. And the majority of this, when we look at, again, that etiology, is a diagnosis of exclusion. The term idiopathic, which is addressed to a lot of the types of scoliosis, really means that we don't have, as a community, the exact reasons or all of the factors that are direct causality. We know some of them, obviously. Another quick fun fact about myself, and I like providing people with history because I think it's interesting, is I was an ancient Greek major in college, and the field of orthopedics actually derives its name directly in relation to scoliosis, in that orthon paidon is a term for a straight child, is to guide growth. And if you go to Chicago at the American Academy of Orthopedic Surgeons, our symbol is a guided tree, which is curved and is a play on the staff of Asclepius. Asclepius had a single staff and a snake around it. The caduceus has nothing to do with medicine. The United States Army made a mistake by putting the caduceus on their military ambulances during World War I. And that's the first time that you'll see the caduceus, which is a symbol of Hermes or Mercury and is more prone to travel, which is why he's on the top of Grand Central Station. Asclepius, on the other hand, was a human being believed to live in somewhere between the 6th to 10th century BC. And he was a healer, a local healer who became apotheosized, or in other words, became a god or considered a god. And he had an island that on the shore, all of the merchants would basically ask you what your ailment is. They would then make a cast of your ailment in clay, and you would pay for that and then go out to the island and leave it as an offering to Asclepius. Scoliosis itself, the term was coined by Hippocrates. It's in his works that we still have, our translations and our manuscripts. He coined the terms scoliosis, which is curvature in the front to back plane. He also termed the terms kyphosis and lordosis, which is when someone's standing towards the side, the natural or sometimes pathologic curvatures of the spine from front to back or back to front, depending. Now, the history of scoliosis as a treatment has long been a history of torture. Hippocrates himself had what was called the machine, which is a derivative later on used similar to the rack, where the deformities would be addressed with ropes and cables, and patients would be stretched out, and different types of massage, etc. Was sort of a brutal form, and it didn't get much better. The first surgical intervention for scoliosis didn't happen until 1914 with Dr. Hibbs. And you can see the treatments that were initially done back there is simply another form of torture. They would put patients into serial casts after the surgery. We didn't have very good anesthesia. They didn't have antibiotics at this point. So quite a traumatic and tortuous um, undertaking. Even the non-surgical treatments borderline were fixed on torture with serial casting of adolescent girls in the formative years of their psyche, to be put into these types of devices obviously has more than an effect just on the general health, but the mental health as well. Once antibiotics came in, they began to fuse the spine with, basically it was to just patiently open the patient's back and then scrape it up a bit and throw some of the bone from their hip in there. And these are two of the gentlemen. Cobb is the angle that we use to measure it. And there he is. He's one of the first chairmen of orthopedics at HSS again. And my fellowship was named after him. But they actually had good results considering the times and the options. Even today, we still have body casting at several sites. Probably about a dozen sites across the country specialize in casting of younger children. Another one of the workhorses is the brace. And while the braces have evolved over time and years, they have an impact. We refer to this as brace scarring, is that even without a surgery, there's a scar that's left on the psyche from having to endure the treatments of braces for children into their adulthood. But I do bring up, this is Scoliosis Barbie in her Milwaukee brace in an attempt to help children, identify themselves. But if you look at this, having to wear this at school is again another form of a psychological torture. I've taken this picture from Pretty in Pink, and I artistically, I think it kind of sums it up, what some people have to go through, even treating the brace non-operatively. I'm sorry, treating the condition. If you look at the spinal instrumentation that's been used over the years, it looks like torture devices. When we look at the classifications, though, it has quite evolved. We've gotten much better at predicting curvatures, predicting the types of pathologies and how the curves will progress. And those instruments, although, I would say in my career, I've seen them evolve greatly just within the last 20 to 25 years to creating a scheme that now this is how I perceive my planning, depending on how a patient comes in and has severe curvature. So again, to take a step back, you're talking about when we're looking at the whole population, scoliosis is 10 degrees of curvature. Things like surgery are not until greater than 50 degrees. But what's really happening, and when I say three-dimensional rotational deformity, is that if you look at this schematic of the spine, it's a torque. One side is rotating, creating a compression on a part of the bone on one side, and tension on the other side through the rotational torque forces. This ends up leaving the bones sometimes wedged. And thus structurally becoming permanent like that. And the best way for me to describe it or look at it is like a chain link, chain links where there are certain degrees of freedom within the rotation of the spine itself before the anatomic constructs start to impinge its rotation. But what happens is once one locks, it starts to disperse that to the next level, and so on and so on. And so this is a preoperative and postoperative picture of how what's happening when we do that. We call the Adams forward bending test, which is to stand where the Norman Rockwell standing behind the child leaning forward. And seeing that there's a rotation of the chest itself relative to the pelvis. Now, when those severely curvatures appear, this is how it starts to pass on into other regions of the spine and causing that buckling and the ultimate failure of the spine itself. So again, it's a three-dimensional deformity that it's difficult to just characterize with two-dimensional X-rays. And the other thing that becomes important as an adult is kyphosis. And what that is looking at what I don't want to say that it's not necessarily the hunch of but as we get older, we lose the height of our discs, and our chest cavity begins to the word again Hippocrates would use is kyphos, and that means to fall kind of forward, and so the biggest complaint that I will hear when we talk about presentation of patients is scoliosis. Well, the majority of the people that we see young in age have no pain at all, but the severity of the concerns of people lead you to feel like they need to grab your attention and say that there's a lot of pain there, and it's kind of a chicken and an egg when you look at does it cause it, or is it consistent with the natural history of a population of patients without scoliosis? And they're fairly the same, but there are some risk factors for things like that in terms of, obviously, if the magnitude gets very high, or if the location of the curve happens at junctions of the body parts. Patients who are elevated body mass index or are sedentary do have an increased risk of pain. But again, the term we use, pain catastrophizing, is that the real need to kind of communicate that you have a problem and you want it addressed. So that curvature of scoliosis, once there, again, the majority of what we're talking about is idiopathic, but there's a lot of things that cause it in other situations. And once that occurs, you substitute idiopathic for whatever is the causal relationship. So, for instance, congenital means from birth. And what that means is that either certain vertebra didn't form or did not separate during intrauterine development. Again, the majority is there on the second dot is idiopathic, and that can be different depending on when it presents, whether or not someone's less than 3 to 7, which would be prepubescent, or adolescent, which again is implying things like hormonal. We also know that there is a brain-body connection that, when disturbed, causes what we call neuromuscular scoliosis, or the brain-body connection, and that is seen with not just dramatic disease, but even things like Parkinson's later on can cause a type of adult neuromuscular, which is not as obvious as some of the more children's diagnoses. And then adults, again, scoliosis being defined as 10 degrees, as the disc or disc degeneration occurs, we call it degenerative scoliosis in the lumbar spine if the lumbar spine starts to collapse on itself. And then as surgeons, different procedures over the years, we've noted that if done in certain situations, can lead to a post-surgical deformities or correction of the spine like that. So why is this such a driving factor, and why would you do this to, talking back to Dr. Hibbs in 1914 without antibiotics and anesthesia? What is the concern? Well, what does scoliosis do to someone is that with progression past 50 degrees, this slide illustrates, if I were to take a CAT scan and look at this slice of imagery, that's the person's lung fields and the heart. If my pointer works, this is the patient's heart, and this is the distortion of the lung fields, which, when you look down here, this is a pulmonary function test of volume. And so the area within this is that of a patient without scoliosis, This is the volume of somebody with this type of magnitude. And so what happens is there's a restrictive lung disease that develops. That restrictive lung disease ultimately causes a different type of hypertension, and that hypertension can be fatal and it shortens people's lives. Why is it important also when looking at age? Well, at 10 years old, when the majority of young ladies are entering, or you know, for females, the growth spurt occurs between 8 to 12 years of age, and for genetic boys, that occurs maybe 2 years later, and sometimes even longer. But in babies with scoliosis or infants, this can be fatal because you need to get to 10 years of age without curvature of the spine in order for more than 50% of the adult volume of the lungs to be developed. And it doesn't really get to 100% until about 15 years of age. And when you look at the lung tissues as themselves, much of the breathing sacs, the alveoli, we call them, are present at about 4 years, but they get to be corrected at about 8 years of age. Those airways which develop at birth also have to develop vasculature or blood flow in and out to be able to communicate air to the blood system. And those develop according to the size of the lung. What does this mean? It means that those guys operated back at that time because there was an increase in the expectancy of death. Lives were shortened by about the time of less than 40 years of age. So a quick status update in terms of, well, when we hear about scoliosis, we think about school screenings, and when is it picked up? The majority of people that I see, or adolescents that I see, the parent and the child usually say, why wasn't this ever picked up? This was never noted before. The issue is, again, that it starts out right at that age and it comes on quickly just as you start growing. So I always say, use your summer vacations when you're wearing, when parents can see their children in bathing suits and less clothing, looking for asymmetries and whatnot. I bring this up right now because around 2004, there was a little bit of a backlash from the United States Preventive Services Task Force, who tried to recommend the removal of school screenings. And you did see a large dip in that, and some of the proponents for keeping them was again the school nurses and the Scoliosis Research Society. Basically, they drew a conclusion of inadequate evidence, but didn't acknowledge some of the statements that were being made on a different level. So now the Scoliosis Research Society, the American Academy of Pediatrics, the American Academy of Orthopedic Surgeons, and the Pediatric Orthopedic Society of North America do recommend screening for girls annually at 10, 11, and 12, and once for males between 13 and 14. And what are some of the other developments that we kind of see in our office now is that we have our own scoliometer app, and I have it on my phone. And I don't like to promote one versus the other, but in order to measure this, in the office, it's nice that you can pull out your Android or iPhone and be able to measure the scoliosis directly off the app. Another thing I love to bring up, because this is a concerning thing, not just for adolescents, or it's also present for adults, is that sometimes scoliosis isn't scoliosis. Patients with herniated discs or fractures, etc., the muscles, your body is pretty smart, and it tries to avoid hurting yourself further. And so you can have muscular spasm where you see this person is leaning away from the pain. And this was a patient of mine. It looks like just a curvature of about 15 degrees, But on closer inspection, you can see that they actually have a fracture in their lower back. Part of it healed and the other part didn't. And so what do? They actually need to stand with a curvature. After I corrected the fracture itself, the scoliosis straightened out. And this is much more adaptable for preserving someone's motion than some of the other procedures that are done. The other big topic in scoliosis has been working the genome, and there have been multiple chromosomal locales that have been tied to scoliosis, but none of them directly show causality. So what do we look for as physicians? We look for our goal is to determine what the risk factors are for progression. Who is going to develop curves that are at risk for reaching higher magnitudes, and who is that's their body shape and it's going to stay that way. We definitely have some of the factors in terms of remaining skeletal growth. If you see a curve young, it means that it's likely that it's going to progress more than some of the other ones. Gender, females end up with more operative curves than boys on an 8-to-1 ratio. The location of the curve is at risk for progression. The majority occur in the thoracic spine, which is higher up, but curves that can occur in the lumbar spine tend to have a greater effect on the way someone stands and their overall posture, etc. Curve magnitude also is important at diagnosis. So if someone comes in and they have a 40-degree curve and I just saw them for the first time, that's a big risk factor. We still look at skeletal age, and we look at the pelvis in terms of how patients' growth plates come together, and we look at the avenues of the cartilage and pelvis, the triradiate. Now the majority, we have a hand classification system, which is a lot less radiation in terms of if I'm going to watch someone, again, getting an X-ray for scoliosis is like getting an EKG for the heart. And instead of irradiating someone repeatedly who I'm looking for risk factors, sometimes a simple X-ray of the hand can tell the bone age, which limits, again, exposure of radiation over the person's lifetime. So this is just a study that, again, shows, the reason why I bring this up is a lot of these studies came out in the early 80s, and they were the result of following patients in the United States Midwest over time for more than a decade in many instances. And it basically shows that the lower or less skeletally mature you are, and the more large or larger that your curve magnitude on initial presentation are, the higher your risk is for progressing on to higher issues. Now, which curves are a problem that I was discussing about shortening life and into adulthood? This is where we get the numbers that we use. Curves that are less than 30 tend not to progress. So when I say progression to adulthood, I'm referring to skeletal maturity. I'm talking about when someone's skeleton itself is no longer going to grow with regards through growth plates. And so if you get to skeletal maturity or adulthood with a curve less than 30 degrees, the likelihood is that it will not progress. You may have a slightly higher rate of back pain in adults, and the magic number of 50 degrees was shown at that time to progress at a rate of greater than 1 degree per year for the rest of the patient's life. So if you present at 13 degrees with a 50-degree curve, and you're going to live hopefully more than 50 years, you're talking now about a 100-degree curve. What about progression in these curves? Again, less than 30 degrees is unlikely to progress. Greater than 30 degrees, but at 30 degrees, usually goes about another 10 to 15. Greater than 50 degrees progresses 1 degree per year. 60 degrees while as an adolescent does not necessarily affect your heart and lungs, 70 degrees in adulthood causes decreased volume and, again, lung hypertension or daily strain on the heart just to oxygenate the blood system with the lungs. This data will never be reproduced again. And the reason is that no one is going to be willing to allow their children to get to that point. So a big thing that we thought was going to be great was the Scoliosis score. Again, this was a genetic test that we plopped down swabs. We got a score, and we could still do this now. Insurance doesn't cover it, of course. But basically, it identifies certain people's risk and categories of progression, et cetera, based on certain genes. In practicality, it's not as helpful as we had hoped it was. It still doesn't change when identifying who's at risk to a great extent. So this is the treatment, basically, if we're talking about adolescent idiopathic scoliosis as an overall look. Curves less than 20 degrees can be observed. We follow them with regular x-rays or radiographs. And as patients get near maturity, if it's less than 45 degrees, that time can increase in terms of the intervals. Bracing, we do this in immature or skeletally immature patients of greater than 25 degrees and less than 40 degrees. We have a bracing study, which was excellent in the New England Journal of Medicine that came out in 2013, which basically said bracing works, but you have to wear it 16 hours a day. Any more than 16 hours didn't do very much. Less than 16 hours was not adequate. We have studies where we put heat monitors into the braces to calculate how long the patient is wearing it. And then one of the places that I worked at, I trained in Delaware at one point. We found that children were leaving them on the nights, the heaters at night, and trying to log hours with the brace by putting them on the heaters. A big development, I would say, in the last 10 years is that Schroth, physical therapy and exercise-specific stretching and bending and physical therapy for curve type has evolved. And this came out of Spain. And I think 10 years ago, there were 2 actually trained therapists in the area, and that number has exponentially increased. Again, insurance doesn't necessarily pay for it. It has to be done specific to the curvature of the patient, so there is a prescription required. And some of the effects have been very good in terms, especially with the developmental curves at some lower magnitudes. Another big development is low dose radiation. With our X-rays now are about 10% of what they used to be in the day in terms of exposure. And this is important, we think, long-term for things like radiation exposure of certain tissues, especially for developing females with breast tissue. I wrote this paper a few years ago in one of the orthopedic journals, and it just to stress about when we call something idiopathic, 8% of the time that we call it idiopathic, we're even wrong. And the MRIs are still very important for determining other causes of scoliosis. Talking about surgery, the goals: stop the progression, correct the three-dimensional aspects of it, because that affects the organs. Try and keep the affected vertebra shorter rather than longer, and try and get spontaneous correction by doing a better job of alignment. Then our goals become things like cosmesis, balancing, and other types of correction. The reason why we're able to do this so well and what's developed, again, over those 20 years is neurophysiologic monitoring. When the patient's asleep, we can actually send electrical currents through the brain and spinal cord with contact on the skin, just like an EKG, and monitor what those signals are doing during the surgery and while we're actually moving around inside. The technology in terms of just even hospital beds allows us 360 degrees of access to people. The imaging and the guidance with intraoperative aspects. And we have all of this at Valley, the state-of-the-art intraoperative guidance and monitoring with robotics for safe placement of instruments and the surgery itself, to be able to monitor as we place instrumentation or hardware. We can actually test them and see if they touch things like the spinal cord, et cetera. And then there's nothing more important than, you go through something like a surgery, and the post-operative care has just improved. People are in the ICU now more and I point this out, it's more for nursing care ratio. It's when someone's had this type of surgery, I'm not having you in the ICU necessarily because of the trauma to you. It's more that the nurses are on a 2-to-1 care level for that type of patients. And we have some neurologic beds like that. ICU is just for a better term, I guess, just to call it that. But now we are able to mobilize people right after surgery. We try and get people up and moving around. And if I do a surgery on Monday, it's most likely that the person will be home before the weekend. And this is, again, the course looks something like 3 to 5 days of hospitalization, 2 weeks of rest at home, 6 weeks of mobilization and homeschooling, 3 months to resume normal activities, but no sports. And then at 6 months, you can start gym and sports. This is, the best way to describe this is these surgeries and treating patients with scoliosis is really a multi-specialty approach between the primary care physician, the hospital itself, the post-operative care, and the surgeons. And this is what a typical operating room will look like. There's a lot of hands on deck. There's a lot of people's input and a lot of care that's going on. I do like to, a little shameless plug real quick, is that I am still trying to find ways to be less aggressive in what we do. And I'm happy to say I was one of the first to put in, or was the first to put in the magnetic corrective devices in children, where basically we allow them to grow. There's a magnetic conductor in the child that limits the number of surgeries that they would need to have. And you can actually elongate with this magnetic driven device. I point that out because, again, a lot of people dabble when it comes to spine surgery. But when you're talking about scoliosis, just make sure that it's a scoliosis trained doctor. So degenerative disc disease, and what does that mean for adults? I'm skipping over to what, when you hear, you've heard of maybe a relative or yourself, you show up in the doctor's office, you've had back pain, and the doctor says, you have scoliosis. And I commonly hear, well, I didn't have it as a child. And the correct actual aspect is you didn't have it as a child. And what we're most likely talking about is that scoliosis is the last stage of degenerative disc disease. If you think about the human disc as a shock absorber, and I liken it to a car tire, is that as you let the air out of it, it's not as stable and it starts to rotate. And so as that rotates, it does that curvature that we call scoliosis of the more than 10 degrees. These curves tend to be less magnitude, so they're not necessarily 50 degrees, but they start to impinge or affect people more because they are advanced arthritis. They start to impinge upon nerves, and thus they have a greater effect on the patient or person's quality of life. This can happen through several processes, and I broke them down here from the etiology standpoint. Is that There are a certain number of patients who had idiopathic scoliosis as children, and they have just as much of a right to develop degenerative arthritis in their lumbar spine. Then we have what we call de novo scoliosis. That's, as I described, someone who develops arthritis newly. Then there are things, salvage. Again, that's when the person has had surgeries or corrections or fusions in their spine, and the body is trying to adapt to those. The good news with this is that the overwhelming majority of this treatment is conservative in nature. It's pharmacologic. We start off just like we would with back pain, but we are limited when it comes to things like surgical options, things like injections, steroids, opioids, physical therapy. All are options to try and treat the symptoms as they are. There's activity modifications, aerobics, yoga, everything that we would still treat. I would be less likely to become involved in doing surgery on someone. Not that it's not more possible now. It is, because of minimally invasive approaches and aspects. But there are consequences to treating instability. A quick note on bracing. When we talk about scoliosis, again, the goal for adolescents is to prevent progression. In adults, you're grown already, so you're not really preventing progression, you're treating pain. And so when you see these controversial talks about, oh, bracing doesn't work for this, well, again, what are you using it for? Now, the big issue with scoliosis in adulthood is not necessarily the front to back. It's the side to side, or looking at the curvatures in terms of somebody's position of their head over their body. And what these are health-related quality of life measures. And we notice that as people's heads in their alignment start to slip forward, start to lean forward through whatever the means are, the quality of life starts to go down. The ability to walk and function starts to become a problem. And this is difficult because part of life is to actually kyphos, or to fall forward. And that's, as we age, we need to see the ground. We need to have better perceptive skills in our surroundings, because our reaction times and whatnot are not exactly still there. And so the goal for this, anytime you would ever need surgery, is to restore that balance. So this is where you do hear about adults having scoliosis surgery. It's to restore that front to back balance, and try and have someone able to again maintain a horizontal gaze, or look, at the ground in front of them, and at the same time try and alleviate things like you hear about, such as stenosis or nerve root impingement, or correction and stabilization of instability. So, in summary, what's new in terms of scoliosis? Well, some of the genetics has been promising. We're decreasing radiation. We've shown that some of the oldest techniques, like bracing, are greatly effective for preventing surgery. And the correctional technology, the ability for us to treat patients with guided care, has greatly changed within the last 20 years. What is not, we need better screening. We need to identify this better. Again, genetics would be nice, long-term studies. We need better triage. It's not in the best of our med school training to pick up on some of this. We need better risk identification. In other words, who's at risk and who's not, what medical comorbidities put us at risk. And then the other goal would be to, let's get less invasive if possible, because that has effects both physically going into over the course of a person's life, but also psychosocially, and how a person sees themselves and interacts with society and develops. And then obviously, we have to get better at the costs of everything and trying to decrease the cost. So I hand it back to Parminder.
Great.
Thank you, everyone.
Thank you, Dr. Faloon. Yes, there are some questions that have come in I just want to remind everyone at home, please try to keep your questions pretty general. Although we have Dr. Faloon here, it's very, I would assume it's very hard for him to really give out, really specific answers to some questions. So I'm going to try to generalize some of your questions that have come in. But the first question is, can scoliosis cause leg edema?
Can scoliosis cause leg edema? Uh, in general, the answer to that is going to be no. However, if someone has a severe curve, there is the possibility that the major blood vessels in the junction between the lumbar spine and the pelvis begin to get impinged. In other words, as the discs collapse and rotate, the ribs can start to fall into the pelvis. And so you could get kinking of the great vessels and certain blood flow characteristics that the body can't compensate for. That would be an extreme case.
Okay, thank you. So this is a little bit of I think a specific question. I'm going to try to generalize it a bit. Could having the Harrington rod when this person was much younger have anything to do with being diagnosed with spinal stenosis?
It can. I'm having been trained in scoliosis again. I see a lot of Harrington rods, and I love to point out that if you get a total knee replacement, the success was considered 10 to 15 years. The majority of Harrington rods that were put in when someone is 13 and 14 don't become a problem until you're after 40 or 50 or when your discs start to degenerate. So for with what the goal was and considering the time, Harrington rods have gotten a bad name and I think undeservedly. Now, that being said, when you've had a spinal fusion, regardless of whether it was a Harrington rod or the more recent instrumentation, as your discs degenerate below the Harrington rod itself or the fusion mass, you can get arthritis and overgrowth at those levels and below, and it can contribute to stenosis. Definitely, yes.
Okay. And then this person has a granddaughter who's a year and a half old, has SMA. Is she a candidate for surgery?
Um,
Hard to answer, right?
That is very specific
Yeah.
and very dependent on, again, what type of surgery, what's the goal. There might be options for, again, there's so many things like magnitude of the curvature, bone mineral density. I mean, that's a really tough situation, and that requires a very specialized treatment protocol and I mean, you better vet your physician on that one.
Okay, thank you. If you are older and scoliosis was not mentioned until you were in your early 50s, what is the best course of evaluating seriousness? If breathing seems to be affected, what doctors do you see first?
So again, I think if you listen to my talk in there, that the majority of people who are told that they have scoliosis in their 50s is they actually developed in their 50s. And it's more of a degenerative arthritis or severe. It can be severe, but it's a degenerative progression. And it definitely can affect the breathing. Think about it this way again: as that lumbar spine starts to sink, the ribs can start to fall into the in the abdomen and whatnot. It increase the pressure of your abdomen, which also increases the pressure on your diaphragm. And then your diaphragm can't really create the volume of inhalation and exhalation that you want. Did I answer that question?
I think so, yes.
Okay.
Thank you.
And
Is
so I'm
there,
sorry. And so you do want to see if you've been told you have scoliosis and that scoliosis is severe enough to warrant some kind of further evaluation, you should see a scoliosis or a deformity surgeon.
Great.
Yeah.
Um, and is there any evidence of the onset of scoliosis following knee replacement surgery?
That is not, I am unaware of any medical literature that would describe a association of those two things.
Thank you. And there's quite a few questions here about the Schroth method.
Yeah.
Can the Schroth method reduce or reverse curve in an adult, or is it intended for adolescents? And then how effective is it?
So again, everything has a time and a place. And so there is a difference between the curvature of adolescents and adults. And there are different goals. Again, the goal of the Schroth method in adolescence is going to be to do exercises that are trying to correct, even in the slightest, until someone can reach skeletal maturity. So there is the possibility for a corrective capacity. Once your bones are formed, your bones are formed. And other than arthritis, it requires trauma or some other external force to change the structure of the bone. And so a lot of times the Schroth um, techniques for adults is more towards what I was saying is the problem with scoliosis in adults is the symptomatology. It's that the degenerative portion of the lumbar spine is now impinging upon a nerve, and you're learning stretching maneuvers and whatnot to unimpinge certain things. Whether or not that affects magnitude or the size of a curve, I think is yet to be proven in large studies of large groups of patients mathematically.
Great, thank you. And then would you take an 88-year-old patient who has scoliosis?
There's a time and a place for everything. I've seen 88-year-old people who run marathons, and I've
Mhm.
seen a lot of people don't make it to 88.
Right.
So again, a time and a place, and there are studies where they've looked at the scoliosis surgery in octogenarians, and that's typically in adults. I try to do more focused surgeries, more minimally invasive things where, again, that adult has a particular problem located within the scoliosis, whether or not that's a particular pinched nerve or a particular complaint. And if there's something that can be done minimally invasive, whether or not it's a pain management intervention or a minimally invasive surgery that doesn't have detrimental consequences by doing it, then I usually I'd like to give you your options and your odds.
Great, thank you. And is there anything adults can do to prevent scoliosis from causing problems later in life?
The most important thing that I could probably suggest is your bone mineral density and your bone health. This is especially prevalent for females, where after menopause, bone mineral density begins to decrease, and while when bone mineral density becomes osteopenia or osteoporotic, we always discuss the risk of pathologic fractures. That would be breaking bones while falling from a standing height, like hips or wrists or shoulders. But the other thing that bone mineral density does affect is the progression of scoliosis. If you've got really bad bone mineral density, there's a good chance that your spine collapses faster and sooner. So vitamin D and calcium, regular checks of those. Especially the vitamin D levels has been something that we've kind of been focusing on, and staying active. The most important, if I could tell you to do one stretch on your own, if you have scoliosis as an adult, is hamstring stretches. The lumbar spine begins to affect your pelvis, and it shortens your hamstrings, and they get tight, and it ends up pitching you forward, like I was showing with some of those images the sagittal imbalance or the posture of falling forward.
Right. A couple of these questions seem a little specific. So I'm going to go on to one last question. Can scoliosis cause neuropathy?
So to be specific, when using the term neuropathy, neuropathy by definition kind of implies that there's a problem within, or pathology, the path within the nerve itself. So when you hear about diabetic neuropathy, you're hearing about the blood sugar levels are affecting the nerve itself, and then the nerve becomes a problem. Scoliosis can cause what we call radiculopathy, which is really pressure on a nerve. That implies that either the bones or arthritis is overgrowing, and so that's taking up space. That's the Greek term we use, stenosis. Stenosis just means decreased space. Arthritis means inflamed joint. How does the body try and stop a joint from moving, which is what a joint's job is to overgrow and try and stop it from moving. And so, again, being specific with the terms, neuropathy is really a problem within the nerve itself. Scoliosis, when causing nerve problems, is more causing pressure or stretch on the spinal cord or the nerves leaving the central nervous system.
Great. And I think that's about all the time that we have for questions. And so I want to thank you so much, Dr. Faloon, for your very informative presentation this evening on scoliosis. And thanks for taking that time to educate everybody.